2012, we started our first clinical trial of using a new medication for a condition called hypophosphatasia. And this when we realized that we actually need a multidisciplinary team. We put in a business case, and it took years and years of perseverance to be able to then get a team which consisted of specialist nurses, therapists, and administrator. Because of our experience in managing and undertaking clinical trial, we were actually given a nationally commissioning for quaternary service for hypophosphatasia. And this was great because this allowed around £150,000 every year to further expand our MDT team. In 2020, Dr. Amish Shenoy joined our team, and now we are one of the international centers for clinical trial. We're very fortunate because in pediatric metabolic bone disorders, there are a lot of new medications coming up, and most of the sponsors are looking to deliver this at Manchester because of our experience. And I'll start with hypophosphatasia, and this is the first clinical trial we set up in 2012. It's a rare genetic disorder caused by deficiency of serum alkaline phosphatase. And just this cartoon to summarize what this condition really is. We need inorganic pyrophosphate, which is PPI, to prevent calcification in extraskeletal tissues, and that prevents calcification in arteries and calcification where it shouldn't occur. In bone, there is high concentration of alkaline phosphatase. It breaks down inorganic pyrophosphate and facilitates mineralization of the bone. So alkaline phosphatase is very important for mineralization of the bone. And if there is deficiency, the mineralization doesn't occur. And this is a condition called hypophosphatasia. And it can be quite severe. And when it is severe, mortality is very high. If it is detected in pregnancy, almost all children die within first year. And if it is detected within first 6 months, 75% of these infants die. So the survival was very poor in this condition. So we started this clinical trial, and our first patient was all the way from Prague. And it wasn't easy because this is a small pharmaceutical company which didn't have much money. So they said we could do the trial, but we can't pay for the transfer of the patient, as well as the cost of managing this patient in pediatric intensive care unit. And we were very fortunate that we were able to engage with the insurers in Czech Republic, and were able to get the funding to bring the patient here. And then this patient stayed here for 6 months in our pediatric intensive care unit and then was transferred back. So it wasn't easy, our first patient, but we persevered and brought this patient here. There were other centers in Europe, but they didn't pursue this because of the challenges of bringing this patient into our centers. And this is what this condition is. It causes severe respiratory failure because of the way the ribs are completely undermineralized compared to the normal radiographs I've shown here, and the lungs, which are not well formed. And within 3 months, we were able to grow the skeleton. We were improve the lung function. But in a real world situation, even in the trial situation, in a rare disorder, when they're surviving, it's very hard because we have new challenges coming up. In this case, the patient you see here responded very well. We had publications coming out of it. And as you can see that over 3 years period, there was significant mineralization of the skeleton, and the child who would have otherwise died survived. The challenge we had was that we were finding respiration incredibly difficult. And this is where we found that there is this complication which can happen in these patients, which makes the airways floppy, and therefore they collapse during expiration. And therefore they require new strategies of ventilation by increasing their peak and expiratory pressure. And we were the first one to recognize this. But when we spoke to other colleagues of ours in different centers, we found that there were 2 more patients in Cincinnati who had similar problems. And this allowed us to publish this, and this has allowed other centers to be able to use our experience, change the ventilatory modalities in managing these patients. Now, this medication was licensed because it was brilliant, but we need approval from NICE to be able to use it for NHS. And NICE is really good because it will only approve medication if it is cost effective. And the cost effectiveness data requires finding out the cost of managing these patients. And there was nothing which was there in the literature. And this is where we were able to undertake this investigator-led projects where we mapped the cost of the patients with this condition of varying severity, mild, moderate, and severe. And then we were able to submit this to NICE. It was a good experience because I had to sit down with our finance team, our coding team, to find out how we get paid for the clinical activities we did. And that actually was very helpful because that allowed me to understand the NHS financial structure. And I was able to use this experience to expand my MDT. My business case was going nowhere till now, but with the costings I was getting, I said, well, I'll be doing this activity. Our MDT will be doing this activity. We'll be generating this income. And that's how I got success in getting our MDT team. And with the same approach, we were able to appoint a research fellow who was our trainee, who has now joined our team as a consultant. So I was able to use that experience elsewhere as well. Now, NICE approved it, but there wasn't much data as per NICE. Therefore, they gave a conditional approval, which meant that we had to collect real-world data for 5 years as part of managed access agreement, and then resubmit all the data to NICE. And this is what we led on from Manchester. We oversaw the collection of data from the 3 nationally commissioned centre. I then served as a NICE expert, as an expert for NICE in 2023, and it was unconditionally approved. And since then, we have been able to give this medication to all of our patients without any conditions attached. Again, we are now in a position to be able to analyze the data, and this is what we have now submitted, our data from managed access agreement, which is a real-world experience of managing this condition. So what I have demonstrated here is by taking part in this clinical trial, we were able to get NICE approval. Our participation in the clinical trial allowed us to have a nationally commissioned service for this at Manchester. We were able to lead on collection of the real-world data, and then we got unconditional approval. And there is a new long-acting molecule coming up for this, and we are going to be the lead pediatric center for UK. I'll now bring in another experience of how managing this condition and our participation in research helps patients as well as increase the profile of the hospital. This is a condition where there is hypophosphatemia, X-linked hypophosphatemic rickets. It is rare, but it is much more common than hypophosphatasia. We have around 10 patients with hypophosphatasia, but we have around 30 patients with XLH. And in this condition, there is rickets, osteomalacia, bone deformities, dental lapses, and they have short stature. And this condition is caused by high FGF23, which leaks phosphate in the urine, causing rickets. The standard treatment was to give oral phosphate, but that wasn't ideal, and we were not able to deal with the primary problem, which was high FGF23. And this medication came up, which then allowed us to use it as a clinical trial in patients with XLH. And the results have been fantastic. As you can see, this is one of my patients who had this treatment, rickets at baseline. You can see this significant rickets there, which significantly improved. And by 64 weeks, rickets had completely healed. And we were fortunate to be a center for phase 2 trial, phase 3 trial. There's an interesting story about this. The sponsors came from America to select centers. They picked up Great Ormond Street because they had 100 patients. They picked up Birmingham, and they decided they wouldn't be picking up any other center. They came to us, and the day they came to us, we had the clinical trial patient who flew in from Prague, and the experience we had in bringing that patient and the perseverance we had, they said, well, you would be the center. We didn't disappoint them because we were the largest European recruiter, much more than what Great Ormond Street did. So we took part in phase 3 trial. We were involved in NICE approval because they wanted natural history study data for XLH, and we provided that data for them. We developed guidelines for helping colleagues nationally, internationally in managing this condition with this medication. And then we are involved in the XLH registry. And there's multiple publications which has come out. This is the natural history study data. This is our clinical guidelines, which we developed as part of British Pediatric and Adolescent Bone Group. And this is the National Registry, which Zulf Mughal, my colleague, was the international lead for this. And after he's left, I'm now the international lead. And there's a lot of data coming out from this, which is going to improve and allow us to provide high quality care for these patients with this new medication. There was this data which was there, which was not analyzed, and I requested and analyzed it. And this was patient-reported quality of life with this new medication. This medication was licensed for children more than 1 year of age, but we knew from our previous studies that the earlier we start, the sooner we start, the better the outcome is. We persuaded the sponsors to do this study, which has now been completed. I just presented this in a recent international meeting, and we are about to publish this. And hopefully, if it is approved for children less than 1 year, it will improve the outcome further. Now, moving on to changing clinical practice. And this is one of the review articles we wrote, and this was one of the most difficult articles we wrote. We had a number of revisions of this, and the reason being that we wanted to change practice. And there was not much evidence, but we had a very strong pathophysiological basis for changing the practice. And we had a clinical experience, which we felt we need to be able to let all of our neonatology colleagues know. Metabolic bone disease of prematurity is a problem which is seen in premature infants because they're unable to have enough minerals to mineralize their bones because of predominant calcium deficiency. They have this rickets problem and osteomalacia. Biochemically, however, this presents as low phosphate level, and the practice was to give phosphate, and that made things worse. And it was not uncommon for us to see children with these problems having fractures and rickets worsening on oral phosphate supplementation. We in the Northwest were able to give advice on oral calcium supplementation, but throughout nationally and internationally, oral phosphate supplementation was still practiced. With this article, we were able to then change practice in most of the centers in UK, nationally and internationally. We were also able to contribute towards changing their guidelines for management of this condition. We've been able to present this nationally, internationally in meetings, in endocrine meetings, in neonatal meetings, and my colleague was leading on this, presented in a national perinatal meeting, and they invited him to prepare a consensus guidance, and he's been working on it, and it's almost ready. So this is what was highlighted when I received my MD research degree from University College London. This was from their alumni. Be the change that you wish to see in the world. And that struck me, and this demonstrates how we were able to change the practice of managing this condition. We have collaborated internationally, and this is a collaboration which I'm very proud of. This was a collaboration which was actually set up by Professor Mughal with a team from Pune, and they were doing a lot of epidemiological studies on metabolic bone disorders, bone and mineral disorders. I've been collaborating with them since 2016. We've had a wonderful time with a lot of grant application success of around £270,000 in GBP, but in Indian money, it is huge. We've had multiple publication, and this is one of the ones where I'm very proud of, because this was a large study of 2,500 children, which was done at 4 different corners of India, where the whole team went and collected clinical data, biological samples, and I had the opportunity to go to one of the centers and spend a few days collecting samples. And it's a great collaboration which we have with this team. We have a small group of pediatric consultants who look after metabolic bone disorders, which is the British Pediatric and Adolescent Bone Group. It's a fantastic group. We meet twice a year. We discuss the challenges we face. We also discuss all the challenging cases. We rotate our chairmanship. I've been fortunate to be chair of this organization since 2022. And what we did was we realized that it was getting incredibly difficult for our colleagues, especially trainees, to attend conferences. So we used our funding to organize their travel, but our funding dried off because we're a small organization. We tried to get industry funding, but we were successful last time, but this failed this time. And we realized that the best way forward was to become a charitable organization, to be able to have subscriptions so that we can generate funding, so that we can then use the money for research and also for teaching and training. So we've got multiple research projects going on, and we've got generalized arterial calcification of infancy, which is a rare disorder. We are one of the main international centers undertaking a lot of clinical trials on this. There is osteogenesis imperfecta. There's no licensed medication. We've been using bisphosphonate for the last 30 years. It is all right in patients who have mild disease, but for the ones with severe disease, like the ones I have demonstrated below, it isn't that effective. And we've got this new medication which is available. We have one of the largest recruiter for this in UK. We've got 9 patients who are currently undergoing clinical trial. The phase 2 data has been fantastic. So hopefully we will get this medication license, and this will benefit our patients. This is our team. This is an old photograph. Some of them have left, some of them have joined. We have a fantastic bone density service. Most throughout the world, it's DEXA scan, which they use, but we have advanced techniques of measuring bone density using QCT, PQCT. We have got orthopedic and radiology team to support us as well. And we've got a very, very good children's clinical research facility. And this is our 2 nurses, Ella and Michelle, who look after our patients with metabolic bone disorder. They do an incredibly difficult job of coordinating their visits and making sure that the patients are satisfied and they remain recruited in our trials. Again, my colleagues, fantastic. They all are inspirational. They really work hard in providing high quality care, and they do fantastic research. Grateful to families, grateful to my secretary, Joe, who's brilliant, and my family and friend who motivate, inspire me, and also my greatest critique. And this is what I read this weekend. It wasn't a good weekend. I went to my friend's place to watch football. We lost. And then I found this book lying there in their room. I picked it up and I saw this quote and I thought, this is fantastic. I probably should use this. Look ahead or fall behind. We're still looking ahead, and that is important. Thank you very much for listening. Happy to take any questions you have.
Raja, that was wonderful. Thank you so much. I can see the cartoon applause. It's, ringing out, even if you can't hear it yourself.
Thank you.
Congratulations. Are there any questions? Raja, can I ask, you talked about very rare bone disorders, and there's no shame in doing that. I mean, the work you've done is marvelous. I wondered whether, in fact, the discoveries that you've made in these very rare disorders can put insight into the management of more general or more prevalent bone disorders in children.
Yeah, absolutely. The pathophysiology of the condition and the outcome which we are getting, we've been able to use that in managing our common disorders as well. For example, X-linked hypophosphatic rickets is different from nutritional rickets, but the lessons we have learned from that has allowed us to manage other conditions where the FGF23 is raised, and that has allowed us to use the medication in other conditions as well. So yes, the patients have survived, and that has allowed us to understand, uh, for example, in hypophosphatasia, what other challenges and problems can occur. Uh, what are the other areas where alkaline phosphatase, which is deficient, works, and how we can able to manage those conditions. And also, it allows us to understand the pathophysiology of the condition and also of what exactly these molecules do in our body.
And is the maxim earlier the diagnosis, the better the outcome?
Yes. In all these conditions, they are progressive, uh, and therefore early diagnosis, early treatment is always beneficial. For example, in osteogenesis imperfecta, I showed an image of patient with severe disability, with severe deformities. If early treatment is available, the outlook is completely different.
Fascinating. Absolutely fascinating. Are there any questions from our audience?
I do have one, if you don't mind.
Sorry, Yasemin.
Yeah, I do have a question, if you don't mind.
Please.
So yeah, thank you so much, Roger. It was an amazing talk and very interesting research and also publications. So I just wanted to ask, and I'm really interested to know that what advice would you give to our early career researchers and also our clinical fellows who are interested in both clinical activities and also research?
Yeah, I think that the first advice will be grab every opportunities which comes to you. Absolutely grab it, because you just don't know what it will lead to. And the clear example is the patient we flew from Prague. We had this opportunity to bring in, we persevered, and that allowed us to become a center, and everybody recognized it. We have reached a stage where if there is any new molecule which is coming from metabolic bone disorder, they come to our team to be able to undertake those research trials. So yes, the important thing is grab every opportunity which comes to you. Don't let it go.
Sound advice. Sound advice.
That sounds great. Yeah, thank you so much. So if you don't have any, sorry, excuse me, please, Andrew.
I was going to say, I think we should hand on to Andrew.
Yes, if we don't have, we do have one. This is a comment from Sean for you, Roger, in the chat box.
Thank you, Sean.
If you don't have any more questions, I am delighted to hand it over to Professor Andrew Morris, who's going to introduce our next speaker, who will be Professor Ben Parker. Andrew, hand over to you. Thank you.
That's great. Thank you so much, Yasemin. And for those of you that don't know me, I'm a professor of statistical genetics at the University of Manchester. I'm currently head of division for musculoskeletal and dermatological sciences, and I was absolutely delighted to be asked to introduce Professor Ben Parker for his inaugural lecture following the award of his prestigious MAHSC honorary clinical chair. So as some background, Ben is a consultant rheumatologist at Spire Manchester Hospital and the Kelburn Centre for Rheumatology. He's a specialist in the management of complex connective tissue diseases and provides a regional tertiary specialist rheumatology service for the northwest of England. In his NHS practice, Ben manages the award-winning biologics services for high-cost drug therapies. Since his appointment, Ben has led many service initiatives that have improved patient care, including development of a large regional specialised rheumatology service for patients with complex rheumatology problems, establishing the Greater Manchester Biologics Optimisation Network, and provision of a young adult rheumatology service for patients transitioning from paediatric to adult services. I know Ben best for his very active programme of clinical research, where he leads on a range of projects in the NIHR Manchester Biomedical Research Centre, investigating treatment, comorbidity and outcomes in lupus. Ben also acts as principal investigator on many clinical trials in connective tissue diseases and is UK chief investigator on several trials in lupus at the Calgren. Since 2022, Ben has been co-director of the NIHR Manchester Clinical Research Facility. And in this role, Ben oversees the delivery of many clinical trials and studies, which have recently included many urgent COVID-19 studies specific to T-cell immunity throughout the pandemic. Ben has previously been a member of the BSR Clinical Affairs Committee and acted on their behalf as a clinical expert for the 2019 NICE clinical guideline in rheumatoid arthritis. Ben also sits on the Abstract Selection Committee for the annual conference of BSR and was a member of the Lupus UK Research Peer Review Panel from 2015 to 2021. So many congratulations, Ben, on this very well-deserved award of MAHSC Honorary Clinical Chair. And I know we're all very much looking forward to hearing your lecture.
Thanks very much, Andrew. That's very kind of you. I'm just going to share my screen. Please shout out if it doesn't work. Right, so thanks. So I'm going to focus a little bit on my work in lupus, but as Andrew hinted at, there's a few other things that I have done and continue to do. So thank you to MAHSC for awarding me this chair. I'm very, very pleased to receive it, and thank you for inviting me to speak today. So I was just going to cover a few roles that I do currently and previously and hopefully into the future, and just give a little bit of update around lupus and the clinical trial work that's going on. It's probably worth noting that both myself and Raja work within the CRF here in Manchester, which I don't think by design we're both talking on the same day, but it's quite a useful thing to remind us all that the CRF is front and centre of a lot of experimental medicine research in Manchester. So I have what could be described as a portfolio career, or a less focused career if you're being mean. I'd like to think of it as more of an interesting career. So I'm a consultant rheumatologist, as Andrew says, at the Calgren Centre for Rheumatology, where I lead the specialised rheumatology service and the high-cost drug service since I was appointed, working alongside lots of people who are very experienced, and until recently Ian Bruce, who's recently left the service. It's worth noting the Calgren Centre is a very active research centre before I came, and it continues to be an active research centre now. Since 2022, I've been co-director of the NIHR Manchester Clinical Research Facility, and I would describe myself as an academic clinician as much as I have quite a broad research programme in lupus and connective tissue diseases, and a significant clinical trial programme in lupus. However, it didn't start there. I originate from Leicester, two of the most famous exports from Leicester at the top. I was going to hopefully put in some celebratory England football videos, but that didn't work. And I've got a big sister, and I was football mad for a long time. And the reason I'm in Manchester, strangely enough, is I've been a Man United fan since about the age of 8. My favourite player was Brian Robson, pictured here, and there's me running the sports stadium and the kit the following year. So I went to Liverpool to start medical school in 1995 and graduated with honours in 2000. And after a brief stint of working, I thought that was too much. So off I went to Australia with my then girlfriend, now wife, and had a year in Australia. So that travel across seas is not a new thing for junior doctors. It's been going on for a long time, and actually should be encouraged because it's a brilliant life experience, a brilliant medical training. Working alone in the middle of nowhere is quite an interesting experience when you're a first year SHO. And then I came back to Manchester, picking the city so I could go and watch my team at Old Trafford. I started my SHO rotation at Manchester Royal Infirmary and my North West England training here in Manchester and the North West in rheumatology. So I just need to pause for a second because there was a question earlier around what advice would you give trainees, and I think my advice would be find a mentor. So as many of you know, Ian and I have worked together for a long time, and at his recent leaving do, we established that we first met, and I think in 2005, when I was a second year SHO doing my membership, and I developed an interest in lupus at that point and was introduced to Ian as perhaps an interesting person to get to know. By 2007, we published our first paper together on the use of steroids in SLE. And in 2008, I was successful in being awarded a Manchester BRC prize for doing a PhD, and then an arthritis research UK fellowship there afterwards. So since then, and throughout all that time, Ian has been a mentor, a supervisor, a colleague, and a friend. And I think that's a really important thing to anyone coming through, is to find those people, and they will help and support you moving forwards. So what do I do now? Well, a lot of my time is spent being a consultant within the tertiary service at Manchester Royal. And there is a very large SLA service which has been established for many, many years, offering a regional service to the whole of the North West. This is an accredited Lupus UK Centre of Excellence, and we were re-accredited back in 2023. But we also have quite a long history of managing complex rheumatology patients with slightly more broader disease diagnoses. And research is part of our normal clinical practice. Patients are recruited to clinical trials, to observational studies across all of the conditions that are managed in rheumatology. More recently, we've established a regional MDT to support the use of biologics in giant cell arteritis, and that's a successful initiative that's been going for the last 6 years or so. And since Ian's left, I've taken over trying to provide the obstetric rheumatology clinic in St Mary's, which has been a more recent career challenge to navigate. So one thing that I have done over the years, I think, is impact clinical practice, both for high-cost drugs and for lupus. But in terms of the high-cost drug service at MRI, the day I was appointed as consultant, I was invited to run the high-cost drug service, which at that point had about 500 patients within it. And as part of the MAHSC Improvement Science for Academics Cohort 1, along with colleagues who are in the photo below, we established a virtual biologics clinic at Manchester Royal Infirmary. In 2014, we started to work on the biologic pathway developments across Greater Manchester, which influenced prescribing across Greater Manchester. And in 2016, we led the implementation of a large biosimilar switch program at Manchester Royal Infirmary. And a number of these things have resulted in prizes and awards. And I must take my hat off here to Vanessa Reid, our lead specialist pharmacist, who did an awful lot of the work alongside me on these projects. These led to an invitation to help on a national level when it came to national NICE guidance. And in 2015-16, I acted as a clinical expert for BSR on a very long, difficult, challenging multi-technology appraisal for biologics and rheumatoid arthritis. When I accepted that invitation, I was told it would be very short and sweet and a very easy thing to do. Around 2 years of our lives were spent trying to navigate that process. Despite that, in 2017-18, I applied and was successful to become a committee member of the Rheumatoid Arthritis Guideline. So working with NICE is a really interesting experience because it shows you the other side of how you access drug therapies in rare diseases in particular, but also high-cost drug therapies. And it's one of these things that I think a lot of drug companies and trial development forget, that there is a cost-effectiveness evaluation in the UK that needs to be thought about when designing trials. So back to lupus. For those of you that aren't up to speed with lupus, I'll do a 2-slide revision. So lupus is an uncommon multi-system connective tissue disease characterized by autoantibody production, particularly against nucleic acids. It often follows a relapsing and remitting course, which causes both inflammation and damage. It has a very varied clinical presentation, which is challenging to manage, challenging to live with as a patient, but challenging to research as well. It has a very excessive female to male risk ratio of around 13:1, with a peak onset in the childbearing years, which brings additional complications when trying to manage and research patients. As you'll all know, it's part of the broader connective tissue disease family, and there are overlapping and shared manifestations across a number of conditions. So the clinical features of lupus are very varied. We won't go through them all, and no one individual has all of these manifestations, but it's worth noting that it's normally a multi-system condition. It has multiple potential clinical features, and therefore it's also worth noting that the more severe features are much more common in non-Caucasian populations. So when we think about how we do research and clinical trials, we need to bear that in mind, that there is an ethnicity variant and gradient in the actual condition. Despite lots of advances in therapy, there is still an increased morbidity and mortality in lupus compared to the general matched population. And in the younger cohorts, that's around 4-fold still. This is data from 2016. In early disease, that's often due to activity from lupus or complications of the treatment, but in later disease, it's often related to comorbidities such as cardiovascular disease. And this is a slide I've shared before, but this is one of my patients I've been looking after for a long time now, which really does go to show how lupus remains relapsing and remitting and treated with lots of steroids and cytotoxic therapies and toxic drugs. So each of the spikes in the blue line is a flare of the disease. The higher the number, the worse the flare. And to get into a clinical trial, you have to have disease activity that's over and above the red line. It's worth noting at each occasion, this young lady wasn't eligible for a clinical trial, so some of our worst patients are not actually generating evidence on new treatments. But what this does show is that there are lots of repeated flares in young people, that high-dose steroids are still used. And actually, even in the modern era, this is quite difficult to avoid. The other thing this shows is that when you have disease flares, activity can cause damage over time in lupus. And this graph shows that in each increasing point is a damage item on the damage index, and damage is been recognised to predict further damage and predict more overall mortality. So the higher the damage index, the more likely it is that there will be a reduced mortality in this individual patient. So there are many unmet needs in lupus still, despite advances. It remains a severe and relapsing disease for many patients. There's still a very high utilisation of toxic therapies and therapies that are not particularly effective. It's quite difficult to achieve good disease control still, and damage and disease occurs in younger patients. There's still a lack of new therapies, and partial response is common, and there's an ongoing excess mortality. So with that in mind, I was going to look at the research highlights that I've over the last 10 years or so that addresses some of those unmet needs. Initially, my PhD was looking at cardiovascular risk in lupus, and my PhD thesis was trying to understand the interaction between inflammation, drug therapies for lupus, and cardiovascular risk. Trying to understand the significantly increased risk of cardiovascular disease in lupus, and this has been building on the work in Manchester that had been going on for at least a decade before I started. There were two components to my PhD. The first was an epidemiology study of metabolic syndrome in lupus, and the second was an experimental medicine study looking at endothelial dysfunction in lupus, looking at both damage and the function. So I showed this slide a lot through my PhD. This was the thought process as to how enhanced cardiovascular risk in lupus could occur, and it generally felt that there's an interaction between classic cardiovascular risk factors like smoking and blood pressure, episodes of inflammation that is a key marker of active lupus, specific antibody profiles, particularly things like antiphospholipid antibodies, and the treatments that we give, particularly steroids, that can all act against each other and through the vascular endothelium that would increase the risk and rate of accelerated atherosclerosis and ultimately result in a high cardiovascular event rate. This is another slide I showed an awful lot through my PhD, and that's my arm from 2008, where we did endothelial function here in the clinical research facility, looking at flow-mediated dilatation of the brachial artery. This is a test that looks at brachial artery reactivity and a response to a 5-minute ischemic stimulus, and it is been proven to predict future cardiovascular events. As well as looking at endothelial function, we looked at endothelial damage, looking at what was then termed endothelial microparticles, which are shed from the endothelium in response to adverse stimuli, such as classic risk factors like smoking or oxidized LDL, or lupus-related risk factors such as complement activation. And you can measure the released endothelial microparticles on flow cytometry. So we had two markers of endothelial dysfunction, a vascular marker looking at what was going on in patients, and a flow cytometry microvesical marker looking at damage. And the paper from that showed that overall, our patients with lupus had worse overall endothelial function than controls, and that confirms something we already knew. It also confirmed that patients with higher disease activity had worse endothelial function, and And more importantly, it also showed that we can improve those things by controlling disease activity. So my PhD had 2 time points of patients with lupus, and what that means is that you can modify cardiovascular risk in patients with high disease activity by treating the disease activity, which sounds self-explanatory, but wasn't necessarily always the case. So since then, and since taking up my consultant role here in Manchester, I've had ongoing research portfolio working with the broader lupus research group within the university and the Biomedical Research Centre. And I've been fortunate enough to supervise a number of clinical and non-clinical PhD students who generated much of the work that I'm about to share, as well as MRes students and MSc students. And the main research areas have been across shared manifestations within other connective tissue diseases, ongoing work in comorbidities in lupus, as well as some treatment response and safety of biologic therapies in lupus. So I'm just going to do a whistle-stop tour of these, so apologies if they're a bit quick. But we started off by taking the microphysical work a little bit further. My colleague Owen McCarthy, pictured above, and colleagues in Manchester Metropolitan took this work forwards, where we collected microphysical samples from patients with a number of different connective tissue diseases to see whether or not what we found in lupus could be replicated across. And what we found is that microparticle levels were associated with vascular dysfunction across connective tissue diseases, and that they may act as a role of novel vascular biomarker in connective tissue disease. And this probably reflects the shared pathology that happens across connective tissue diseases with shared manifestations and shared risk of comorbidity. And this sharing of complications, immunopathology, and disease activity is quite a common theme in our research to date. And Sarah, who's been recently awarded her PhD, has looked at this in our LEAP cohort, which was the Lupus Extended Phenotype Study, where we've recruited patients from across Manchester with a range of connective tissue diseases, including lupus and Sjögren's syndrome, undifferentiated connective tissue disease, and myositis, for example. And Sarah's work has been looking at how we can identify common factors across those connective tissue diseases. But one thing that came out of this work was that health-related quality of life, which is a really important measure for patients, much more so than everything else we've so far mentioned, is significantly impaired across all connective tissue diseases, even in what would be considered a mild disease like undifferentiated connective tissue disease on the top right on the left-hand diagram. But actually, not all patients are affected equally across connective tissue diseases. There are subgroups of patients who exist within each strata of severe, average, or mild impairment to quality of life. This is not dependent on their clinical diagnosis. So what that means is that there are subgroups of patients cutting across the connective tissue diseases that we already demonstrated have got shared cardiovascular risk, shared vascular risk, but also have shared impaired health quality of life. And one of the big things we've been looking at is how we take this forward into clinical trials, because one thing we learned at the very beginning of Sarah's PhD is that clinical trials for connective tissue diseases are quite difficult. They're quite poorly representative of patients. They have a high exclusion rate. They have a low participation rate, and one could argue they have a low success rate compared to other conditions. Part of this is because patients can fulfill several different classification criteria if you apply them without examining patients. And this means that overlapping patients are often excluded. So we published data on this, that the clinical trial eligibility of patients with connective tissue diseases is quite low, and that impacts on our evidence base for managing them. So what are the lessons from looking across connective tissue diseases? Well, we know that there is shared immunopathology. We know that interferon gene signatures cut across. We know that antibodies cut across. We know that manifestations cut across the diseases. We know that there is a risk of comorbidity that cuts across all the connective tissue diseases. And we know that patients living with these conditions have an impaired quality of life within certain subgroups. And that lack of clinical trial participation has a high exclusion rate in those patients, which means our evidence base is poor. So one of the things moving forwards is this information that Sarah will be taking forwards, I hope, will be, can we treat across subgroups of the connective tissue diseases within a clinical trial context rather than by disease alone? So that instead of having a trial of drug X in lupus and drug X in Sjögren's syndrome, can we have it based on what their antibody profile is, or their molecular signature is underneath. This will obviously require shared outcomes, which is difficult across diseases. It will obviously require a way of identifying those subgroups to allow enriched populations, but certainly it would be much more beneficial for patients and cheaper for pharma to do it in that way. So moving on, we've continued to look at comorbidity in lupus. And one of the things we've moved towards is cognitive dysfunction, and working with Michelle, we've looked at the concept of brain fog in patients with lupus, which is a highly prevalent condition, but rarely is it an actual manifestation of active lupus. And one thing that Michelle found through an extensive experimental medicine study was that brain fog doesn't seem to actually reflect impaired cognitive measures when you objectively measure them, but what it does seem to do is reflect cognitive fatigue. And so attention is impaired, and in essence, patients have to work harder to maintain the same level of cognition, which is tiring for them and gives through the concept of brain fog. So the lesson from that work is that brain fog is really important to patients. It impacts their life. It's common, but actual cognitive impairment is probably less common than we think. And that brain fog can be adversely affected by active disease. And that means there's a target for intervention when we're trying to manage brain fog as a symptom for patients. And finally, from research highlights, there's other things going on, but one of the things we've got, one of my current PhD students, Mia, looking at the safety of biologics in lupus, and this is using the Biobiologics Register that Ian set up around 2010 with about 1,400 patients currently enrolled. And what Mia's work to date has shown is that when you look at patients receiving standard of care or a range of biologics, the risk of adverse events such as infections is not particularly enhanced with the more recent therapies, which is reassuring, although you can find clinical risk factors for infection, such as increased steroid use. And Mia is looking ongoing in her PhD at predictors of response to lethal treatments, which is a really important part of the work moving forwards, is to try and identify which patients will respond to which therapy. Just going to cover a little bit on research leadership, which has been part of my career since the beginning. In 2013, I was fortunate to take over the academic foundation program lead here at MRI, and then in 2014 became training lead at the Wellcome Trust clinical research facility, as it was then called. And following that, in 2018, became medical director of the adult facility here at MRI. In 2022, I became co-director and co-lead applicant on our successful rebid for NIH funding. And it's worth pointing out here that the MCRF has a vision to be a world-class exemplar of experimental medicine research and clinical trials. And it's the largest such facility in the UK and supports delivery of early phase clinical trials across 6 sites of Greater Manchester in adults and children, which is the only site in the UK that is available to do that. I've been co-director and training lead for a while and have a number of responsibilities. And what's interesting is how this applies to your own research. So once you start sitting in application review committees and in the early phase safety committees, you start to realise that you can improve your own research by looking what everybody else is doing. And that's one of the other things that I would advise any early stage researchers to look across what's already happening. It was mentioned in the introduction that we supported COVID research a lot, and I was part of the trial delivery team through COVID, particularly in wave 1, acting as PI and sub-I on multiple COVID trials, which was a very, very interesting experience. I've never had so many adverse events in a trial, but also helped support the coordinating trials recruitment rota across the 2 sites to try and allow Manchester to be a high recruiter to multiple studies. We also supported urgent public health studies within the CRF itself, recruiting to the ESCAPE study led by Shaz Ahmed here in Manchester. And we were very, very proud to recruit over 1,000 staff members in a very, very short timescale in wave 1, looking at COVID antibody response over 6 months. And with the first global study to demonstrate prolonged T-cell immunity after COVID infection. And that received quite high news coverage at the time. So finally, just to finish, current and future work. So the thing I haven't mentioned so far is the clinical trials that we undertake here in Manchester in lupus. And I think this demonstrates a number of things. One, it links my roles across the clinical service with a large tertiary regional service for lupus. It reflects the clinical research programme that is embedded here in Manchester and part of the clinical service, both in outcomes and experimental medicine, being particularly relevant to what we do. And also, as I mentioned before, my role is within the MCRF allows a degree of phase 1 and 2 expertise from looking at what everybody else does to ensure that we can deliver and become a leading trial centre in the UK for early phase clinical trials in lupus. However, as we've already demonstrated, trial recruitment in these conditions is challenging. And as well as publishing in the CTDs, we've published a paper, particularly in lupus itself, showing that overall eligibility for phase 3 trials that are currently available is around 30% of patients with severe active lupus. And this was due to a combination of trial design, difficult inclusion criteria, and comorbidity. And it's really important when we think about this is it reduces the actual validity of results, it reduces the evidence base with which we use to treat patients in the clinic, but it also is a reason why there is a higher than expected failure rate of trials in lupus, with only 3 licensed therapies since the 1950s, only 2 of which are available in the UK. So within Manchester, I've acted as a PI in many clinical and commercial clinical trials, particularly in lupus, but in other conditions as well, across all the phases 1, 2, and 3, and have acted as UK Chief Investigator on a number of phase 3 of the early phase trials. I've also helped and supported colleagues from across the region to deliver investigator-led trials, particularly with colleagues from UCH. And most recently, we've become the first active site in the UK for novel cellular therapies in lupus. I'm just going to spend 1 minute talking about this because I suspect this is particularly what all of my training experience seems to have led to, which is around trying to deliver novel complex therapies in a relatively rare condition. So CAR T-cell therapy has become the great hope of changing and revolutionising the treatment of patients with severe and refractory lupus. The patient I demonstrated earlier with the recurrent spikes of disease activity would be a prime candidate for receiving CAR T-cell therapy. In a case series from Germany of 8 patients, all 8 patients achieved remarkable improvements in disease activity, antibody production, and proteinuria, and all of them achieved drug-free remission going out to about 3.5 years. This is incomparable to any other treatment we currently have for patients with severe and active lupus. So as a result of this, I was very keen that Manchester led, or at least participated in these trials. And I'm very pleased to say that the combination of having a tertiary service and NIHR Manchester CRF that has phase 1 experience, having an excellent hematology transplant team here at MRI who lead the CAR T service, we were able to achieve the global first dosing for phase 1 trial in CAR T and lupus and became the first UK patient to receive CAR T for any rheumatic disease earlier this year. I think it's a really positive note to end on to say that Manchester can and does lead on novel trials, not just in lupus, but in many conditions. So that's trying to end on a marker of hope. So there's lots of people to thank, too many to mention. I've already mentioned Ian as we went through, but all the colleagues and staff at the Kelvin Centre within the CRF, all the students in the Lupus Research Group, obviously my family, wife and children. So thank you very much for listening.
That's fantastic, Ben. Thank you so much for that excellent whistle-stop tour of your outstanding work. We do have time for some questions. Maybe I can start with a quick one, Ben, whilst other people are thinking. So you mentioned the fact that in lupus you see more severe features in non-Caucasians. Are there any explanations for that?
Combinations of things, really, Andrew. Things like genetics and would suit your background, I suspect. The different ethnicities have got a different susceptibility both to disease and particular manifestations such as renal disease, which is often the things that drives outcomes. When you look globally, sometimes that reflects healthcare systems and access to healthcare, but it also, I think, just reflects the innate nature of lupus being a much more prevalent disease in those conditions. But it's important to recognise, because if we're researching, we need to make sure that our research participants look like the people that we look after in clinic.
Exactly. Yasmin.
Yeah, thank you so much. I do have a very quick one. So thank you so much again, Ben, for sharing your great journey and also your wonderful research with us. So considering your substantial roles, excuse me, in research and also clinical practice, I just wanted to ask, how do you exactly balance these responsibilities? How do you manage your time effectively?
I'm not sure I do. I think I've learned from people who do it very well. So that there are a number of people on this call who manage to do an awful lot of different things, and I think that's what is a very useful skill to pick up. I don't think you're born that way. I think you can learn to manage. You have to be very efficient, which I think is a tricky one if you're a bit disorganized. But no, I think learn from the people above you. They've often done that, been there, done that, and seen it, and you can mirror how they work.
Fantastic. Thank you so much. So I'm not too sure if we do have any more questions, but if we don't, so this will be the end of our event today. Okay, and a comment from Sean for you, Ben, in the chat box. So yeah, thank you so much, everyone, for joining us today for another MAHSC inaugural lecture. And once more, I would like to congratulate both of our professors, Professor Padidela and also Professor Parker, for their prestigious and outstanding achievements. Thank you so much, everyone. And we are looking forward to seeing you again. Thank you.